So lung cancer screening is a practice of secondary prevention for early diagnosis of lung cancer. We have a 20 years history, even more, for the accepted method to do this practice, and this is low-dose CT. Low-dose CT is an extremely accurate method for quantifying small findings that may represent lung cancer. So the ESTI paper now brings about rules that are quite mathematically derived to prove that this practice can be optimized with reduction of workload, of anxiety for the subject undergoing the CT, and at the end of the day, with an increase in accuracy. So what we are doing with the new guidelines from the ESTI Society for Management of Lung Nodules in low-dose CT for lung cancer screening is to have an apportioned approach that takes into account the risk of a nodule being a cancer, but actually without upon the risk of this cancer being an aggressive cancer or not. So with the baseline CT, we characterize the type of nodule in terms of density, solid, part solid, or non-solid, and this relates with the risk of the nodule being a cancer, and also with the risk of that nodule being an aggressive cancer. But from the second CT on, meaning the 3, 6, or 1 year CT on, we can also characterize the growth rate by estimating the volume, measuring the volume with a software. So the measured volume with the software is indeed an estimate, is not 100% precise, and we take into account this detail, which is very important. We have to account for variability in measurement because that will be the accuracy of the picture that we have to define the risk of the nodule being an aggressive cancer. So at the end of the day, what is the message from the ESTI guidelines? So the ESTI guidelines are saying that with the follow-up CT that we can provide even for indeterminate nodule, we are well within the threshold of time that allows us to prevent a major shift in lung cancer stage. And the major shift is defined by the T1C shift. We have to accept the T1B shift with the annual round, of course, for those negative nodules. For intermediate risk nodules, we actually have a substrata for the definition of such. So a relatively lower and relatively higher risk. Those at relatively low risk are reviewed with the second CT in 6 months because that's the technical demand that we need for such a small nodule. On the other hand, the 3-month control is dedicated for those at relatively high risk because this threshold is a good compromise between the technical limitation that we might have and the actual risk of that nodule having a stage shift. So having said that, the new guidelines provided by the ESTI actually provide an accurate and scientifically proven backbone for lung cancer screening in Europe. And I think most of the trials will make benefit from this, and SOLACE program probably also will. Because within all the lung cancer screening programs, we have a substantial problem to optimize the resources. We don't have time, person time, machine time to evaluate too many things. That's a lifetime fil rouge, isn't it? We need to optimize, and with this in mind, we also optimize radiation and anxiety for the subjects. So that would be the major advantage of the ESTI position paper for management of lung nodules in lung cancer screening. The ESTI position paper for management of lung nodules is going to improve the outcome at the patient level, at the subject level, because the personalized management is indeed tailored to minimize the number of CTs, which means minimize radiation, minimize workload burden, and minimize anxiety for the subject undergoing CT. Also, we're optimizing this threshold for management of the nodules by providing a selected substrata of nodules with faster follow-up. The one that we are used to, the 3-month control, which now appears after mathematical evaluation quite short to actually accurately determine the real estimation of risk of that nodule. So we're shifting along the timeline what is appropriate to be done at the right moment. So we know we have technical limitation. We know we are chasing tumors that are growing at different paces. So we do longer controls for smaller nodules and shorter controls for relatively larger nodules. We're always under the dimensional threshold of 8 millimeters, 500 cubic millimeters to determine the nodule risk. For those nodules, we will always have 3-month control, but for those that are much smaller, actually we can go longer, not just for radiation reasons, not just for organizational reasons, but actually really for technical reasons that prevent us to be accurate before a certain period of time.